I have been giving it all a good thought and trying to see how best we can inculcate those principles in India. So with that brief introduction, I would like to start sharing my slides. 1 minute, I'll just. Can you see my slides? So
Yes,
one thumbs up. Yeah, okay. Thank you. Thank you so much. So this is all about transforming institutional obligation into measurable community impact. And I've been talking about this to a lot of people and wondering how best we can do it and implement it. This is what the traditional paradigm shows, where we have a school-centric kind of approach where the curriculum is driven by internal academic tradition, isolated teaching hospitals, and of course, healthcare delivery and passive community relationship. In 1995, when WHO sort of coined this social accountability and actually went ahead and defined it, they said it is the institutional obligation to direct education, research, and services. You know, there are three-pronged approach that all of us have as far as running of any of our medical schools are concerned. They said that all these should be addressing the priority of the health concerns of the communities that they serve. So that means we move from the traditional paradigm to the socially accountable paradigm, where we will have most of the activities that we are doing directed towards tackling the priority health concerns and having an identification of the needs by constantly talking to the government and the health organizations, and also designing our curriculum so that they fit into this responsiveness. We're trying to do that, but we're still not there. And that is why both Jyotsna and I thought, let us look and let us at least, start a dialogue with all of you to see what all can we do and where all do we stand. So this is the accountability spectrum that Bullen put forward way back in 2016. And he said that we have to shift from passive teaching to an active structural change. And this is, 1 minute, I just put my laser pointer on. So you will see here that this is what we do. We are socially responsible. I'm not saying, I mean, both of us are not saying that we are not doing a thing. We are very reactive to all the crises. I mean, COVID-19 was an excellent example of what happened. We participate in blood donation drives. If there is a flood, there's any epidemic, all of us rise to the occasion. We do have a curriculum, but most of the time, what we're doing is distinct from a core curriculum. There's no core curriculum which says that this is what we have to do day in and day out. So we have to move on to the social accountability phase, where there is a continuous structural integration of what we're doing, and it should be mandated by the institutional policy. You have to have proactive community health needs assessment also. See, I mean, I'm not going to say assessment drives learning, but I want to say it also. So if I say assessment drives learning, because if we are not assessed, I don't say that our students are going to, appear for an exam or something related to social accountability. But if there is no body which will come and say that, yes, what you're doing is in the right place, things will not happen or take place in the direction that we are aiming to be. And the core principles need to be systematically tested and measured. So that is where we should be. I'm talking about a 3 decades of evolution, right from, that definition of WHO, where they actually introduced the concept of social accountability. We had a network building there, where the Training for Health Equity Network was established, and the focus shifted to the social determinants of health. They sort of put a document together, and they increased the focus on community oriented medical education. Then in 2010 and 2012, in fact, that is my FAMER fellowship year, when I was in the US, we had also a brief global consensus meeting in the campus of FAMER, where we had the global consensus for social accountability actually outlining the 10 strategic directions that were there. And all of us in groups sat there and worked out. We had 10 groups, and each one of us was trying to work out the strategies for each and every direction that is named. It would be a good, if people who are interested, or it would be a good idea for all of you to go back to that paper, which will tell us the exact 10 strategic directions, which are absolutely doable, and you could sort of look at it as to how best we can take it forward. Along with that, there was
पूरा कपड़े निकाल के रखो बाद में
along with that, we had the development of the CPU model, which was the conceptualization, production, and the usability model, which was put forward. And there was a first, at that time when it was put forward, we had the first international conference on social accountability. Having said that, we moved on to the 2015-2017 slot, where there was this integration of the sustainable development goals. We had the matrices in place, and the NET released an updated evaluation framework with the expanded metrics. So we had then a whole blueprint which we could use, and a checklist that we could use to determine social accountability in each and every of our places. And of course, the modern imperatives, who can forget, where COVID-19, which forced rapid adaptation, and the focus that's expanded to digital health, global security, climate change, and structural safety. So we had WHO redoing their guidelines, and telling us and focusing on indigenous health and structural safety and cultural safety. So that is what the WHO once more in 2022 put forward, one more addendum to what they had said earlier. And Woolard said that these are the stakeholders whom we should tap, and we should think that they are the important people: the policymakers, the health professionals, the academic institutions, the communities, and of course, the health administrators. And all this was built on a 4-pillar framework. They talked about, and we still talk about, quality, that is deploying best evidence-based practices, where we have evidence-based teaching technologies. There are continuous curriculum updates and integration of modern technology, and to see how these best practices can work and we maintain the quality of them. Along with that, of course, equity, addressing the disparities and promoting fair access by looking into the student recruitment, mandatory training and undeserved areas, and of course, the cultural competency education. We are trying to do that now with the NMC and with the new curriculum that is in place, but it's still not enough. And then, of course, the relevance. We need to prioritize the most important local issues and take them up. So whatever we are doing has to be contextualized to the system and to where we are. So what may be needed when I'm sitting here in Lucknow may not be the same as what I may need in the city of Mumbai. So that has to be tweaked, changed, so that we can focus on prevalent local conditions. And of course, there is the cost effectiveness. We need to maximize health outcomes through efficient resources, sustainable community programs, preventive healthcare focus, and a strategic resource sharing partnerships. So you will ask me, does this happen anywhere? We have some, I have these three examples of the global trailblazers where these three institutes or the universities have actually been named by the net, etc. People who will give you that uh, uh, onus to say or to call yourself socially accountable schools. So we have one in Northern Ontario, the School of Medicine in Canada, where 94% of the graduates serve in rural communities, and the focus is on rural and indigenous health. We have the Sisulu University in South of Africa, whose education is problem-based. There is a deep integration with local healthcare systems and a sharp focus on primary healthcare delivery. And you have the Flinders University in Australia, where the implementation of longitudinal integrated clerkships is there. You have strong Aboriginal health programs and rural clinic schools. So when I saw this, I was wondering, where in India could we say that perhaps we could give this kind of criteria or a medal to say that perhaps you are socially accountability, the schools. And it brought me to two medical schools that I can think of, which are pioneers in the Indian context. One is CMC Vellore, where there is a pioneering the rural commitment, and the MGIMS at Wardha, where there is an early immersion and adoption. And in fact, the family adoption program, I think, has come from there to us in the NMC, which I'm hoping, utilizing the way it should be and not as just a compulsion. We hope that all this will help us to change the mindset of our students also. There will be problems. There are challenges. We have to, and what are they? First of all, there will always be resistance, to the traditional curriculum. There can be resource and funding limits. Large population diversity and rural-urban disparities are very much evident. And of course, the cultural and linguistic barriers. These are the challenges that all of us are facing. In fact, when I interviewed people, this is what they said. In fact, there were some people who didn't even know that there was something like a socially accountable school that could be formed. So these are the problems. So how could we sort of move out of this zone of challenges to some solutions? We could deploy tech-enabled remote care and mobile health units. There could be public-private partnerships and shared resource networks. Let us not forget our traditional medicine. Integration of Ayush and local traditional healers have to be taken into confidence. Why are we saying that, no, this is something that cannot happen? They are all age-old systems in our India. And I feel that they should not be ignored. They have to be also uplifted and taken with us. And there is no need to say, or, there's no need for us to feel insecure in our situations. All these, the Ayush, the traditional medicine should also come together. And of course, there has to be rural immersion into the local language training and the family adoption programs. We can measure them with these indicators. First of all, the institutional activity, the short term. What is the community participation level? How are the students engaged? We can also have stakeholder satisfaction surveys, etc. Along with that, of course, we move on to the midterm indicators, which could talk about the graduate trajectory. What are the students going into the rural areas and practicing out of choice? Where are their practice locations? What are the specialization patterns? And does the community program there in that situation have sustainability? And we can have long-term impact indicators by talking about population health outcomes, healthcare access improvements, and of course, the global health equity indicators. There is a social accountability ecosystem, which I have mentioned all these to you, and they are all there, which will all these, right from AMI to TUF to WHO to GCSA will all help us to make a socially accountable institution. And there are frameworks, and for beginners like us, we could use this blueprint. First of all, conduct a thorough community survey for the needs assessment, engage the stakeholders jointly and early, embed the social accountability explicitly into the institutional mission and values, build on strengths and secure long-term funding, develop a faculty expertise and supportive policies, and regularly evaluate and track the graduates and adapt the programs. We have to see whether we have inculcated enough zeal into our students to say that, no, I will go back to my hometown in the village and make a and serve the community there. With all this, increase in the number of seats, increase, and if everyone starts sitting in the urban areas, I'm telling you, we are in for deep, deep trouble. So the social accountability frontier, what do we take from there? We have to think of climate change and health impacts and the community resilience. We have to be transformed digitally and tech-enabled engagement. Talk about cultural safety. Think about the cross-border health issues and the universal health coverage also. Along with that, the alignment of the SDGs, the Sustainable Development Goals. So ultimately, we have to synthesize. We cannot just think about altruism in the sense, not just think about our focus not on oneself, but on others. I always remember our KEM, not for self, but for all mission statement. And that is what we should also think about. And of course, integrate into the social canvas by embedding the community needs into that institutional architecture and transform the health professions education. So you may say that, oh, this is so much of, talk and just hot air. So I thought, let us look at the Indian perspective. Let us see how we can try and align the educational design with the national health realities. And we have this kind of a landscape, and we have, of course, a rural-urban divide. We have to think of the tribal health. Think of the Adivasi communities which carry disproportionate burdens of malnutrition, TB, and sickle cell disease. Talk about the non-communicable diseases, the rising NCDs, the maternal mortality and the under 5 deaths that we see, oral health inequities, 80% of the dental disease burden falls on the poorest quintiles with near zero specialist access. And of course, WHO has added this in its new version of social accountability, the climate and the environment issues, where the heat stress, air pollution, vector extraction, etc., have to be looked into. So I just love this diagram of this is what we have been doing so far. We talk about education, we talk about service to the community, we talk about research. So all these aspects, if we can align them to community health, our curriculum, and not just hospital training, we will go a long way. It will be a stepping stone towards making social accountability a reality. When it comes to research, questions can be driven by the local disease burden and the equity gaps. And when it comes to the service, active contribution to health system strengthening and access will make our day. So let us shift the focus to community and population health outcomes, to health and wellness centers in the PHCs in the communities, to product of systemic and social and structural determinants, to being systems thinkers, equity advocates, and community partners. Let us forget being just individual disease management systems, just being the tertiary wards, just being strictly biomedical pathology, looking at disease from just the pathology, and from being bedside clinicians and individual healers. Let us move out of those zones to providing socially accountable education. So these are the five core competencies that we thought we should talk about. One is the community responsive practice. Second is equity-oriented decision-making, which prioritizes the marginalized. Then is the cultural humility, which respects diversity. The systems thinking, which sees culture health through policy. And of course, advocacy for vulnerable populations, which speaks for the unheard. I Googled, I looked into the systems, and I found that there is a regulatory alignment. You know, we do have our NMC modules. We do have the wellness centers. We do have the maternal health document. We do have the Pradhan Mantri Ayushman Bharat Health Infrastructure Mission, the PM Abhim. There are the DCI's social dentistry objectives. We have the JSA movement, the Jan Swasthya Abhiyan. There are the ATCOM, uh, everything in place. There is the NHSRS, the National Health Research Commission. And of course, there is the district level, the district level household survey and the NFHS. So we need to move and integrate into this matrix where there is a core curriculum intervention where the community is concerned. The primary focus should be the community, and we move on from the urban versus rural divide to participatory action and rural longitudinal postings. Along with that, we have to think of case-based learning, you know? Ethnographic immersion and traditional healer dialogue, strict health data root cause mapping, and the NGO placements and policy report drafting. That means we have to document what we do and see to it it reaches to the right stakeholders. See this. This is a blueprint. This is the mapping that I have done, taking into account all the centers that I have talked about, and taking into account the NMC, the DCI, the Nursing Council, the Ayush councils, the Ayush Bharat and the health wellness centers, and of course the NHMs. If you look at the five main modalities that I was talking about in the beginning, you know, when I talked about the five core competencies, you can see that most of our councils have actually embedded them into the curricula, you know. So it's all is not lost, but how we do it and how we put it into action is, I think, somewhere lacking. So social accountability is not just like an add-on module. It has to be a disposition. When health professions graduate with all these 5 competencies, and they don't just serve the patients, but they transform systems. And sort of we bridge the gap, and we move from an outdated, isolated technical provider to being a holistic community health system. It brought me back, as I was going to end, I was just sitting there and thinking, what has changed? Let me tell you that nothing has changed. In 2018, I had written this paper for our AHP newsletter. Anshu and Munira will remember this because they are the ones who asked me to write it. And I did, and I wrote about the different shades of social obligation and medical colleges in India. Okay, I just copied it from there. And at the end of that article, I had posed a few questions, just 6 questions. And when I looked at those questions again, I was surprised to see that they still remain unanswered. So I would just like to again, once more reiterate what those questions were. We had 2 questions, which was sort of, I could put it into the first layer. They were just questions, but then I put them into 3 layers. The first layer was the foundational identity. And I had asked at that time, will medical colleges have to relook their mission and vision statements if we have to then see that we are socially accountable? And with the help of a network, of a framework with benchmarks, will we be able to identify factors which shall promote positive health outcomes in the society? The third question that I had posed was related to mechanisms of action and relations. I said, is compulsory rural posting a step towards achieving social accountability? And I also asked about partnerships. Will respectful partnerships lead to transformative social changes, which shall pave a path towards a better understanding of self and the profession? And at the layer 3, I talked about the macro determinants, and I said, will this help us to avoid the clustering health professionals in the urban area? And in the long run, by inculcating the values of social accountability, will we be able to contain the migration of our health professionals? These are the questions that I asked, and I'm sorry to say that still there is a status quo. There are static vision mission statements. There is a lack of rural integration. And without the early interventions in the social values and mandatory rural exposure, or which is just so compulsory that people just go like robots and come back like robots only, not having thought as to what they're doing in that network, the system naturally deposits the workforce into urban clusters, and international migration. So that is what we will continue seeing, unless, of course, Trump does something else altogether. So, I mean, it's not just about going to the US, it is about going all over the world globally. So we have unanswered questions and a workforce drain. Unless we mitigate the urban, we have the urban mitigation, foresee and look into the partnerships and mitigate the migration, answers to all these questions and more will be a stepping stone towards fulfilling our commitment to the society. And that is why I say that the commitment to society requires all these answers. It is not social accountability, I repeat, is not an abstract concept. It is about building through frameworks, partnerships, and a restructured vision. And that vision and that strategy our Jyotsna is going to talk about. So with that, thank you so much, and over to Jyotsna. I'll stop sharing, Jyotsna.
Thank you, ma'am. Thank you. Yeah, the burning questions which you raised in terms of whether we are aligned to our vision, whether we are training our graduates to work for a society, are the questions which I also started my journey into social accountability. Yeah, for those of you who are new, I have a public health dentistry background, and I started my career in as a postgrad student somewhere in 2007. So as I stepped into the field of community-based education, I realized there is so much of potential here for us to train our learners. So during my training itself, I was handling undergrad students, and I could see when we took them to the community and trained them there, what was the impact on such learners? And the learning impact was tremendous. And that made me realize that taking learners out of a classroom setting into the community is absolute important for us to ensure that students have a connect with the community. So most of the times when students join healthcare profession, they do it with altruism. We want to serve the society. We want to do this. We want to do that. But then the system, when it puts them between those four walls, makes them understand that, patient is an isolated case. He comes with a case history, and it's all individual systems that you're treating. Maybe the eye, maybe the heart, maybe the kidney, or something like that. But they refuse to understand that the patient needs to be treated holistically. When the patient himself or herself is not treated holistically, they also fail to relate the patient with his background in the community. And when that happens, the questioning in terms of why this patient is having the disease, are others in the community also having the disease? So these kind of questions may not arise in the minds of the student. So as a faculty for over 15 years, I took my students to the field, and that's where I got to know so much more about what are the factors which influence a learner, how they can actually become socially accountable. So somewhere in 2016, that was when I had my formal training with towards Unity for Health, and what began as an interesting certificate program went on to become even my PhD topic in Maastricht University. So currently, I'm investigating what are the skill sets that students pick up when we take them to a community-based setting. I would love to share my presentation with you at this stage to see how much these factors resonate with you. So, Suchita ma'am introduced us to the concepts of social accountability. And then she posed those 5 questions. And she said, what questions I posed earlier remain unanswered even now. But how can we go about it? Are there any strategic approaches that we can take to address those challenges? So to begin with, we know that social accountability is built on these 3 pillars. So we have education, we have research, as well as service to the community. And this is where our mode of action is going to be. What can we do? As I thought more and more about it and also looked into the literature, I found there were these 5 evidence-based strategies which seem to have worked in a global situation, and there are anecdotal examples from the Indian context as well. When students were exposed to a community-engaged curriculum design, what happened? When they were exposed to a longitudinal community-based education, when the mission of the institution aligns with the admission process, when the competency frameworks embed the social accountability, and the faculty are also trained for social accountability aligned teaching. So these were some of the strategies which came up in literature as well. What about research? So can we look at community engaged research models? What do we mean by that? Can we prioritize research based on local health needs? Can I have frameworks which emphasize reciprocity? What I mean is, research should not be for the sake of research, but how is it actually benefiting the community from where we are getting the data? How can I build the capacity for an evidence-based approach among community as well as my students? And will my impact extend beyond academics, beyond the impact factors? Will it go beyond that into translating into actual action? When it comes to service, I am providing healthcare service, but do I have a need-based service delivery model? Do we have sustainable community partnerships? Can I integrate primary care and public health service with an interprofessional education approach? What is the accountability which exists? And how can I strengthen my workforce? So these were the 5 strategies which came up in service as well. Now to dive into each one of it, what is this community engaged curriculum design? And is it the heavyweight lifting which only the community medicine or the public health department which needs to do it? That's an interesting question indeed. Can we align our learning outcomes with real community health needs? What does that mean? For example, can an ENT specialist look at the reasons for deafness? Why a particular group of people are suffering? Or can they look at geriatric population group and identify at what age deafness starts? And with that background, can they start off with a health screening project for them and also look at the efficiency or effectiveness of the hearing aids which are delivered to them? Can we focus on learning outcomes which resonate with real health community needs? Can we have a situation where the learners are properly trained, the contextual information? And when we do that, it is definitely going to enhance the relevance of the information we are providing to our learners. There is going to be an improvement in cultural competence because they understand the background from where this particular patient is coming. And it definitely addresses the equity orientation. So, to give an example, in the dental curriculum, we have a component of fluorosis and tobacco-related lesions, and we know that it exists massively among the rural population. So can the dental institutions take it up and say, can we have a design with the panchayat leaders and talk to them about what is the problem which their villagers are facing? And based on that, can the learners be exposed to the problem and also identify how they can go about creating solutions? And this particular topic is not being taught only in public health dentistry. It occurs in pedodontia, it also occurs in oral medicine, and it's also there in oral pathology and in other specialties to some extent. For example, prosthodontics, where the hazards of tobacco and how it affects the gingiva, the dentures is learned, and in periodontia as well. So can we have an integrated curriculum which focuses on such real community health needs? Some of the suggestions I had was, can we have a community curriculum advisory board? We have a UG committee, we have a PG committee. In that, can we have a component where the community curriculum advisory board says, look, these are the 5 priority areas where our field practice area people are suffering from. So can we look at curriculum which focuses on these things? Can we conduct an annual needs assessment which feeds the community curriculum advisory board? Can we integrate whatever are the priorities which have been identified into modules and assessments across all disciplines and not just as a public health department, right? So I'm not just pulling this out of thin air. This is evidence-based and as part of the recommendations globally. The second one is the longitudinal community-based education. This, to a great extent, is implemented through the family adoption program. But how is it working? Does it fulfill these objectives? Is there continuity, trust, and deeper understanding of social determinants happening through the family adoption program? There are few dental institutions I know of where deeper engagement happens with the community. But how is it in the other disciplines? Do we have the same in physiotherapy or in Ayush streams or anywhere else, right? What I have observed is when students are exposed to real world context, they are able to analyze and rationalize their clinical reasoning much better. And with that experiential learning, they have an opportunity for transformative thinking. So learners who are not able to understand the social determinants of health or how a healthcare system works, when exposed to a community-based education, are able to imbibe this knowledge very well. And they know what works and what doesn't and how they can be agents of change as well. So, for example, if you're posting students, so this is something which can be done very easily. Can we do a multi-year community immersion track, just like how the NMC curriculum currently is showing? Can we do that similarly in other disciplines? Can we have faculty mentors, not just from public health, but across all health sciences for continuity? Can we ask learners to use reflective portfolios and community project evaluations, which deepens their learning and provides an opportunity for transformative experience? Ma'am spoke about mission, right? She said the vision and mission and how it is. There is a concept of mission aligned admissions. This was being practiced by certain institutions in the country, but for various reasons, we may not have the regulatory approval. But can we be the advocates of change and prove it and show it to the government that, when students were being taken based on how they are aligned to the institution's mission and how they are functioning because of that, can we have a better workforce distribution happening? Can we prove it to the ministry and get this mission aligned admissions back? And this is something which is evidence based. So, can we define these mission aligned selection criteria and go for state government partnership and rural recruitment? But until this policy change happens, how can we do it at our level? So, I had some thoughts on this. We do get students from different criteria categories into our courses across institutions. Can we monitor them and see how they are progressing after their curriculum ends, after their training period ends? How many of them have gone back to the society and how are they working? And what are the factors which have influenced this particular thought of going back and serving their society? When we look at these kind of career trajectories, we are building a workforce which is more aligned towards social accountability. Can I embed the competency frameworks using the social accountability principles which ma'am identified? So can we make it accountable and measurable? Can we reinforce this advocacy, equity, and systems thinking in all our training frameworks? If I'm talking about a fracture case, a RTA case, can I bring in a component of advocacy to my healthcare learners and say, look, this is what is happening. Can this be addressed through some legislations, through some system changes which can be done? How can we build in the systems thinking capacity into our learners among all disciplines? This is some more food for thought. Can I have a simple rubric which also has, these kind of community advocacy, equity oriented decision making involved into our competency framework, which the faculty can assess? And when students notice these words, at least they're going to start looking into it and seeing, oh, something like this also exists. How can I make the best use of it? So, how can I map my social accountability competency to existing frameworks, be it as part of the ATCOM module, as seen in the CanMEDS framework? Can I use OSCEs, portfolios, and community project assessments as tools to see that these competencies are being realized? And most importantly, how can I equip my faculty on social accountability aligned assessment? Coming to the fifth most critical factor in education is the faculty development for social accountability. Faculty modeling is essential. So, can I train them? Can I have them being introduced to participatory teaching and community immersion, reflective facilitation, etc.? So, what are my strategies? Can I have some champions who are going to work in this area? Can I give them a training on community responsive pedagogy? Can I include this as a criteria in their faculty appraisal? These suggestions are have been time and tested among other strategies to develop faculty. So can we improve a social accountability component among faculty also using these strategies? Now, I have presented 5 strategies for education. We spoke about faculty development for social accountability. Then we spoke about how you can have a mission-oriented social accountability seat selection process. We spoke about how you can have a community-based project, how you can have a long-term immersive program. And now I would love to hear from you as to what are the areas in which you think you can inculcate the social accountability education related strategies in your context. Please leave a message on chat. And I would also be happy to take in any question on this particular component over chat. So what are these 5 strategies and what do you think you can do in your context, or what are you already doing in your context?
Imran has written in the chat that the family adoption program in association with the college, the students have learned better and were focusing on the socio-cultural factors as well. So I have answered back saying that I'm glad that this is happening in his medical school, in his her medical school, and I'm hoping that everyone also doesn't take it as a compulsion, but takes it forward in the right spirit, in the way it is meant to be. We
Absolutely,
have
ma'am.
Sujata, who talks about oral health programs, tobacco awareness programs.
Yes, and she's coming from an oral medicine background, but she's integrating the social accountability principles into it. Well done, Dr. Sujata. Anyone else would like to share how we are going about it, or what do you think of these 5 strategies? Are they doable in your context? You can unmute and share too if you would love to.
Hello,
Yes.
this is Dr. Farzana. Congratulations for making all of us aware as to how we can embed social accountability. I think so. The manner in which you all have suggested that if we start, then a lot of things are doable. That mindset has to be created, that it needs to be done, and then I don't think so there will be any problem. And already smaller things are being done. But what I think that the thing which has been brought up is that other health professionals like physiotherapy and all, they are not going. But of course, nursing professionals, they are going into the society already. They are going and reaching out to the society. So thanks for enlightening all of us, and I'm sure we can pick up few things and start right away. Thank
Yes.
you.
Thank you.
Thank you,
Thank
ma'am.
you.
Thank you for
Thank you
sharing.
so much for that.
Yeah, there's a pretty important question. Most of the times, it's the community medicine department who are involved in rural and community setting. How can other faculty get involved? What I have observed is when institutions are socially responsive, that is, they have the agenda that they want to serve the society, they make it mandatory for all specialities to get involved. And in the training, instead of having a fragmented or a siloed approach to student development, if all the faculty who are here, at least you guys can start with this. If you start asking questions related to advocacy, systems thinking, how the social determinants might have influenced a particular case, then the learner will also not delineate and say, oh, anything related to social accountability belongs to community medicine. They're going to start integrated that learning. So maybe that's a process which can start from those of us who are here. And that would be my simplest suggestion until we get out of our siloed approach to teaching. Okay, so thanks for sharing that. I would love to move on to the second section here, where
Someone in 1 minute, sorry, Josna, in the
yes,
chat we have Vijay Ethapalli, who's
yes,
talked about as faculty, only the community medicine faculty are involved in
yes,
rural. Yes, as you just said.
yes,
And there comes the role of training and the faculty and creating teaching modules in other subjects. Thank you very much for that. Yeah,
yeah.
go ahead, Josna.
Thank you, ma'am. And the next important aspect is research. All of us are expected to do multiple types of research and publish it also as part of our academic credentials. But how can I build in social accountability into this part of research? These are some of the strategies. Can I do a community engaged research? Can I have a focus? For example, I had a PhD candidate who wanted to work on geriatric oral health. So she said, yes, when I look at geriatric oral health, I find most of them suffering from sarcopenia. So, as a community of geriatrics, I would love to identify how that condition of their tooth influences sarcopenia. I would also like to understand how their thinking about aging itself influences sarcopenia. So, when faculty from a non-public health department start thinking of questions which reflect real community priorities, that's when a community engaged research can happen. And when the participants of your research understand that you're looking at something which is beneficial to them, they're obviously going to be having trust in you, and there's going to be a concept of shared ownership which builds over. If you're doing a study with the ASHA workers and you want to design a cancer study, so involve them as well in your research. So there is an incentive, there is an accountability which gets built in when you look at community engaged research. So every institution can have its own priorities identified. What are the community engaged research, and what are these participatory methods and collaborative methods in which I can conduct community engaged research? Can I also involve my community in identifying what is the problem that is being forced there? Can I identify the needs which are very, very contextual and relevant to local health burdens? So we do a lot of research. I have seen hundreds and thousands of studies where we talk about knowledge, attitude, and practice of something, something, something. Can we move beyond knowledge, attitude, and practice studies, the CAP studies, and look at something which actually makes a change to the participants? Can I look at the typical local health burdens? Can I enhance the policy relevance and focus on this need-based research? Can I have the research agenda? Probably it might align with the district priority on smokeless tobacco use. So how can I have both the components built into the research that I'm doing there? So can I sit with the district health office and have the priorities identified? Can I have a mission aligned research fund? The institutional mission will always have some components related to social accountability. Can I identify a percentage of the research fund being allocated exclusively for that which touches upon social accountability? Can I look at when there is a policy tweak or something, how those research outputs are going to be changed? So these are some of the ways in which we can look at need-based research prioritization. Ethical reciprocity in research, I feel, is very critical. Does my community actually benefit from the research that I'm doing? As a postgrad student in public health dentistry, I did research on oral cancer. So I was interested in identifying pre-malignant lesions and what are the different ways in which I can diagnose pre-malignant lesions. So I did that in an area which was called Kaivara, a field practice area near Bangalore. But at that stage, I did not know how I can benefit my research participants. But looking back today, probably I would have gone back to all the cases on whom I did a biopsy and did a follow-up properly to ensure that they also benefited from the research that I was doing. That would have been my ethical integrity and trust. Can I do a geriatric oral health study and just come back without giving them dentures? And what is the purpose of me doing a research at all, right? So these are some of the ways I think we can go ahead. At a system level, can I include a reciprocity clause to the ethics review? We look at individual patient level. So can we look at the community level, what is the benefit which is going to happen to the community because of this particular research? Can we mandate a community dissemination of findings? We know we do mandate academic dissemination, but is the outcome of research shared with the community? Can we have that kind of a mandate introduced into our ethics board? Can we create a benefit sharing plan with the community so that they also understand the implications of it, right? So these are already practice guidelines in the global north, but can we imbibe some of these into our context and see how well this works or doesn't work? How can I build the capacity of my students and community both for research? Can I teach them about evidence-based practice? Can I look at how I can empower and promote sustainability? Can I train them collect the oral health data using mobile apps? So can I train the community volunteers also to do that? When I do that, it is going to reduce the manpower burden, and at the same time, there is an involvement and collaboration which is happening there. Can I provide this kind of a training using research modules and integrate them onto research teams? And can I provide micro grants which happen? So these are all tiny, tiny things which we think we can practice. And I would love to hear from you as to what you think you can practice in your context. The last one here I have is an impact evaluation which goes beyond publication. Most of us love to see our articles being published in high impact journals. But the real question is, does it translate into action? Is there a shift from academic output to a societal outcomes? So I get quite a few research scholars who approach me for different kinds of consultancies. And I always tell them, what is the impact your research is going to be on the audience? So even if you're doing a genomic study, what is the impact of your findings going to be on the community? So I recently had an oncologist who was trying to understand what is the cancer pattern in his practice. I said, look, this is what is your finding, which is coming up. Based on this, how can you have a screening program to ensure that these cases are caught early? How can you contribute and real context there? So where is the impact evaluation beyond publication? And that is where we're going to end up with a meaningful and applied research. So in the dental context, we know that when pain is there among children, they're going to drop out of schools, right? Or similarly, if there is any other health issue, can I go and restore their teeth and find out that, because the dental pains dropped down, the school absenteeism also dropped down? Can I talk with the education department and show them this data and emphasize on the importance of having good oral health, where my research is being converted into an applied research? Can I have an impact indicator which is very clearly aligned with the social accountability values of relevance, of equity, of cost effectiveness? Can I track the policy influence and community outcomes and show it? Right? Most of our research happens through our postgrad students and undergrad students to some extent. But when you look at the guide or the mentor who's conducting this research, can they have a area of focus? And that can it be a continued trajectory where all these impact outcomes also get identified and translated into real purpose? Can we have a research impact report where the real impact is identified and that goes beyond publication? So can we have awards instituted which highlights that yes, this particular research contributed to this kind of a real change in the community? It could be among your student community, faculty community, as well as among your patient community. So as researchers, I would love to understand what strategies would you like to explore? Are you going to be looking at impact evaluation beyond publication? Are you going to be looking at joint work where the students in the community are both trained? Are you going to be looking at identifying what are the research priorities by sitting along with the community where you're working, and you sit with your faculty and students to identify what are your research focus areas? Can you look at ethical reciprocity to ensure that the research that you do actually translates into some measurable action? I would love to hear your thoughts on what you think is doable in your context.
You
Till
can
you
put in the chat.
till you type in your chat, Swapnil has a question. Is a vascular surgeon who spreads awareness regarding vascular health through Insta Reels doing a social accountable task? Definitely, I would agree on that, because he's creating awareness. As long as the information he's providing is evidence based and not just for garnering views, I would definitely call it a socially accountable task. I'd be happy to hear of your research which is happening, which is socially accountable, where you're working for the community in context as well.
And if not, are you thinking about doing so?
Yes.
I mean, we need a change in the mindset, and we need to see that, yes, as Jyotsna rightly said, follow up. There are so many cases that we feel that, oh, we could have definitely helped this person. and we just, that patient is lost to follow up. And we feel sorry about it. But that is maybe because of faulty documentation, or of course, many people also change their residences. There is no way in which we can find them. But if in the beginning itself we are able to tell our, the population that we would like to help uh, as and when we can, and be in touch with us, will it help? I mean, it's a question that I'm asking.
Yeah, yes, ma'am. And I know that there are a few IRB members and IRB heads in this panel. What is your take? How can you look at research which actually translates into action? Can you look at having those components in your IRBs?
Sujata says diseases prevalent in the society and make that disease identification.
Yes,
Thank you, Sujata.
thank you. Dr. Imran, would you like to share anything? I know you are so keen on the IRB components.
Swapnil writes in-depth interviews of patients with type 2 diabetes mellitus to determine factors influencing lifestyle modification strategies. What deters them?
Yeah, that's a good research topic to explore further, Dr. Swapnil.
I think to put the things perspective together, I think interprofessional education is what we are looking at. I think we had a journey. I'm audible. Am I audible?
Yes, you
Yes,
are.
Imran.
Yeah. What we thought was, because most of the students are studying in silos, and we have adopted a center in the rural area where there is an adopted village. Basically, it's a destitute center where people from poor background are housed, and also there is a specially abled school which is integrated within the system. So when I had gone first as a camp to organize a camp there, then I thought there is a possibility of extending our services to that place. So it became a possibility when our alumni donated a dental chair, and we have established a dental clinic there. And we are currently posting medical, dental, nursing, physiotherapy, occupational therapy, and speech therapy students together. Though the integration or the grouping is in early, but I would like to share that the students are working together. They're very happy to work together. This is the first time the chance has been given to them so that they can work together, though it is not happening in a research mode, but it is happening. They all of them are providing cases, the solutions in silos, but during their journey they are sharing each other's experience, and that is leading to better results. I think the parents are very happy. In fact, the parents of the many children are calling up and telling that there has been a considerable improvement from the day when our students have been posted there and getting the treatment done. These are exciting times where I think the social accountability and what as an institution we can do. Probably, we should look into the research aspects as well. When I put my this entire adoption strategy, uh, having a long-term research data was one of the ideas. We are working towards it, and I'm hopeful that in years to come we will have long-term data. And also, let me share that the students are keen to work together. Only thing is we have to provide them the platform where they can do it.
Yes, thank you for bringing the focus on IPE here, Imran. Very nice. And yeah, if, in that context, Sujata ma'am and I will connect with you at a subsequent timeline. Thank you for that. Yes.
Right now, as secretary and president of AHP, we are, hounding people.
Yes. So yeah, we will
Thank
have some
you.
good news on that front sooner or later. Okay. Moving on to the third arm of social accountability. It is
Chandra, can I say
service.
something?
Yes, yes, Neem.
Sorry. Yeah. This is related to the ethics guideline you mentioned about the community. But
Yes.
the Indian biomedical guidelines, ethical guidelines, 2017 was, I think, the last. They have mentioned about it, what you have mentioned or shown for the WHO. Our guidelines also mention that whatever our research findings are there, they should be shared with the community. And whatever the benefits one is going to get from the research, the benefits should be shared with the community. So we do have that in place.
Yes, ma'am. Thank you for highlighting this particular aspect. Many times it also happens that we have it in the guidelines, but translation into real action, there might be a gap. So
Yes, I totally agree with
Yeah.
it. Means saying that many aspects of the social accountability are already in our curriculum, present curriculum even, but
Yes.
the transaction is not happening properly, and which is in our hand actually. If you see the elements, whatever you were saying for the last 1 hour or so, many are there you can identify in medical curriculum I'm talking about. And yeah, I'm sure it will be there in
Yes, see,
other
I mapped
curricula.
it, you can see it's in there in nursing, it's there in the
Yeah,
DCI.
yeah, yeah.
But
But the
how,
transaction or implementation, then somewhere we have to focus. Anyway, go ahead. It's very nice. Go ahead.
thank you, ma'am. Thank you. And how can we embed it in service? So in most of the institutions, we do have the community service happening, right? So we do go for camps, we do provide different kinds of treatment and other aspects. But how can we systematically align this so that our social accountability components are enhanced? Can we have a need-based service delivery? We go and we conduct a health camp. We say, okay, come for diabetic screening, come for BP, sugar, etc. But is that the real need for that particular population? Can we have a program which goes in for addressing the real unmet needs of that particular population rather than saying, I did this much of coverage or I did this with partnership with so many organizations, right? Can we shift the focus to the community per se? Can we look at the impact of that particular need-based service delivery and say it reduces the inequities which are existing? As a public health dentist over the last 6 years, I have been conducting oral healthcare programs in a very remote village which borders between Karnataka and Tamil Nadu. Just to give it in context, this is a place where Veerappan was very, very active. The notorious person was very active, and healthcare facilities have hardly reached the population there. So sometimes it takes us almost 2 to 3 hours to reach one village and then move on to the next place. So the people in these areas do not have any kind of facilities. But the children, being children, have access to lots of chocolates. And out of 10, I would find at least 7 or 8 of them having tooth decay. And when children have tooth decay, they do end up with a lot of tooth pain, then miss school and swelling and all that stuff. And the nearest dentist is some 80 kilometers away. And rarely will the parents even take them for healthcare setup. So in 2019, when I started doing these camps, I started focusing more on prevention. So I started putting a lot of an agent called a pit and fissure sealant, which protects their teeth. So as we started doing that, and I noticed that out of 7 children who would have dental caries, now the count is dropping down to 3 children out of 10 having dental caries. And whenever we ask them how many times you should brush, they all say twice. And now we are shifting the focus out of chocolates being eaten every day to only Sundays being chocolate days. And we are doing this program on a twice a year or a 3 times a year basis. So children are also becoming more and more aware that chocolates and other things, how much of an impact it has on their health. So children who are sitting in some remote areas are also getting access to care, which is based on their own priority needs. So can we have some such system? If I as an individual dentist can do this, can an institution also do this? Right? So these are some food for thought. Should it be only a public health perspective? Or can a person who is in other discipline also provide an unmet need-based service delivery?
where there's a will, there's a way.
There
And that is
is.
what we're trying to, inculcate and try and motivate people to move ahead.
Yes. Can we do this? You know? Can I have a sustainable community partnership? There's no point in me doing a camp in one place, coming off and doing a camp in another place the next day. But can it be a sustained effort so that my energy is directed in one place and there is a tangible outcome which is happening from that? Can I have an MOU long term? We all have, right? But how is this getting translated into action? Have we done an annual partnership review? Have we been identifying what is the impact of this particular partnership rather than keeping these documents only for NMC or NDC or for NAC purpose? So there is something which we can go beyond in this context. Can I provide an integrated primary care and public health service? So this brings us to what Imran was talking about, having an IPE. So can I have interprofessional collaboration at this stage where students are going to be posted together and they learn together? Can I have an accountability mechanism and public reporting where all my academic audits are related to the public health are made public and people can access it? Because of the transparency, will it enhance my community trust? I share with the people there and say, look, this is the initial disease stage. With this kind of a program that we are doing, this has come down. I don't know of a program which is done by Ramaya, where their field practice area is called Kaivara, and the belt is heavily fluoride prone. So the medical college, the dental college, they all collaborated and they established a defluoridation plant over there to provide clean drinking water to the people. So what is the impact of such a program? Can we have it as a public published report? The last strategy I have in terms of service is how can I strengthen my workforce? That can happen only with training. So when my service component is strong, and that is going to enhance our retention in underserved areas. So ma'am was talking about this very significant aspect where we have migration happening to other countries, where we have a higher concentration of healthcare professionals in the urban area. So can I have a situation where there is more retention in underserved areas and there's a continuity of care happening? So these are some of the models which have been studied globally. And they found that when learners are exposed and trained in the community, they like to go back and serve in the community as well.
Actually, the number of seats that we are having, the 250 practically in all the colleges. I'm scared that all these people will never want to go back home. Maybe they've come from the villages, etc. So that is what we have to now try and inculcate and see that, as you rightly said, Jyotsna, have a proper training so that people can move on and be there for the public. And
Yeah.
but that will happen also if we have the right kind of a setup for the health professionals. Many people have told me in the past that there are no good schools for my children. What will I do going back? How can I serve? I want to go back and serve my community, but I also want my family to flourish, and that is where there is a problem. So things like this also have to be taken into account.
Yeah, I agree, ma'am. This is also aligned with the question whether the hen came first or the egg came first. So are we going to improve our rural infrastructure and then only incentivize our healthcare practitioners to go there? Or is it possible for our urban healthcare practitioners to spend maybe 3 days a month or 4 days a month in a rural area, provide care, and come back?
I
Is
know
that
of,
something we
of
will have
a
a
few
hybrid
doctors
model?
who are doing that, happily so, but they're not enough.
Yes. So can we motivate our members to take this up even more? Can we call for their internal social accountability and say, come on, can we do this? So this is one more aspect which that, and we would love to hear from you as to what you think is feasible on this front. If you are interested in from where I base these strategies, these are my references. And this is what I summarize. I'd be happy to share this infographic with you all. But more than anything, I would love to hear from you all as to what you think about social accountability concept as a whole and the strategies. So the floor is now open for discussion.
Good evening, Dr.
Your
Jyotsna. This is Dr.
references were not
Sujata.
seen. Just show your slides if you want to show us.
I'm good with that, ma'am.
Okay.
Yeah.
Yeah, go ahead.
Yeah.
Yes.
Good evening, madam. And my suggestion is like we have a committee called as a camp committee. I think Jyotsna is our every dental institution is having. And every department, one faculty and one postgraduate and one undergraduate. They will be accommodated in this camp committee. But the thing is like we have two different satellite clinics, which are like around 10 to 15 kilometers away from the city area. The problem is like most of the patients who are visiting to those satellite clinic, they are, they are daily wage workers. Like, so it's very difficult for them to come and afford for the treatment. I mean, get the checkup done and all those things. Number one point. And second thing, this is the kids of those people will be gone to the school. So whatever service we want to provide on the daytime, I think it is not going to give that much impact to these people. I think something extra should be done so that we can give some, services to such kind of a population for the evening clinic or something like that. So that's what I feel like can work
Yeah.
different wonders.
In some institutions, there are student-led community clinics which happen in the evening, Dr. Sujata. So the students themselves monitor how these clinics happen, and there is a faculty who is overall in charge, but the initiative, the activities are all planned and undertaken by the students themselves across the years, not just the third or final year, but from first year itself they get integrated into this. Maybe that's something which we can explore in dentistry or in any of the other health sciences.
Being aware of these situations is half the battle won, and then slowly trying to put it into action. That is also something that all of us should think of. Thank you for those thoughts, Jata.
Thank you, ma'am.
Do we have any?
For students in KM Hospital, 2 years back, a fellowship has been started, Gandhi Medical Fellowship, which is in collaboration with Piramal Foundation. So KM, the donation comes from alumni, and the Piramal Foundation supports it. And the students are then placed for it is a bigger program, but during which there is a 3 weeks field visits, and they go to the rural areas, not only in Maharashtra, but also Bihar and one more place. And they get the purpose is to get them exposed to the challenges in the rural areas, and then the training, whatever is there, apart from these 3 weeks, is to develop that leadership and develop the approaches to tackle the challenges in the rural area. So actually that, because it is 2 years, that longitudinal how it goes and whether the students train through this particular program, whether they go and then later on work in rural areas, that has to be seen yet. But it is a start on behalf of the institution.
Yes, ma'am.
And regarding the service also, as Sucheta said, many doctors may be having it. Maybe they were starting as a camp on their own. They're starting as a camp, but later on they are doing it on a regular basis and visiting the same place again and again. Means one thing I remember is Dr. Shekhar Bhojraj, who is a
Yes.
renowned spine surgeon, and he has a spine. He started going to Dr. Bung's place at Gadchiroli and working, because there no health. He's a spine surgeon, and there are many cases he found related to spine, but where they can't afford the treatment. So he does all the free surgery. But through that, he established an NGO, because as you rightly said, going from Mumbai and performing that spine surgery is one thing, but it requires lot of help later on also, physiotherapies and this. So ultimately, it has now come to that through the foundation, local people are getting trained. Then they look after their own people. They all find out that who needs such type of consultation, and they bring them to whenever he goes. He plans few days a year. And it is not just now the Gadchiroli, but that movement is going around Maharashtra also. Many villages are uh, getting involved. And the research is, an offshoot of that is a research also. So it can start slow and in a local area with some small focus, but it can go big also, depending on the individual, of course, and the circumstances.
Thank you for highlighting this case of a spinal surgeon being so involved in public health care, ma'am. That just goes to show it need not be only public health or community medicine. Anyone
Yes,
can do this, right?
In fact,
absolutely.
even institutions, Derwan is one example where we have a whole institution which is based there and they really do community work. So there are such cases, and I think time has come when we should highlight these cases and institutions and put them up and publicize to see that these things are possible.
Yes.
Yeah.
And if you want to identify at what level your institution is in terms of social accountability, there is the ISAT framework given by TUF towards unity
Yes.
for health.
And the checklist will just help you to show you where you are,
Yeah,
place you where you are.
and place
So
where
At
you
least
self
are.
evaluation.
we should make our students know about such cases, and if possible arrange their visits or uh, get those people to the institution to so that they can hear how they have started and how they have done the work. That can inspire our students. Means that is something which is additional thing.
Yes. And for those of you who are interested in knowing more about social accountability, KLE is shortly going to announce the second batch of Social Accountability Fellowship. So they did this last year, and this year they're planning to have on blended learning with on-site and off-site sessions. So that's another opportunity to equip yourselves. And for those who, for whom reward is the motivation, you can look at the Aspire Awards.
Yes.
Aspire Awards recognize social accountability, and they will give you quite a few thousands of euros. You know, so that's another component you can look at.
Mm.
Uh, yes. Do we have anyone else wanting to share their thoughts, views?
Imran has said student-run clinics is also an innovative way. Yes, as Jyotsna put forward. True. So if not, I think,
Yes, I can add a little bit.
oh, please go ahead.
Oh, basically, I feel all these without. I mean, I'm a promoter of technology, and without. I mean, these days, very high speed, good internet is available in every village, and I have seen lots and lots of situations where the doctor is sitting in the city and the OPD is running in the village,
Hmm.
and there is a constant interaction, and any because 90% of the problems of rural areas are just uh, simple infections or which grow. I mean, the cost of traveling to the city, the cost of I mean, follow up, repeated follow up, I mean, it comes down to a huge one.
True.
So I mean, if we are in fact the cheapest internet in India, and still, I mean, if we are able to use this method to take care of at least a certain percentage of case. I mean, no matter of wishful thinking, what we may do, doctors will not go to rural areas if there are no schools for children. I mean, there's no point in saying have egg first or hen first. Nothing, it will not work. But
Yes.
technology can be implemented overnight.
Yes.
And
Yes.
also, there is a lot of, I mean, Aadhaar card has been linked to Abha ID, and I mean, the work is going on that 1.4 billion people, they will have their electronic medical records sooner or later. I mean, it has been made compulsory in all medical colleges, and gradually I am also seeing it is coming up with certain private sector also. So obviously, if I mean, time is coming when on the back end we will be having uh, electronic medical records of large number of people. I mean, technology is available. Still, when we talk about social accountability, we talk about something as if we are still living in 80s or 70s. We have to upgrade ourselves also, that we are living in 2026. So apply what is available in 2026. I mean,
Thank
still
you.
a lot of thought processes of 80s.
Yes, Dr. Bedi, so true, so true. Thank you for that. And yes, we should explore this digital means.
Yes, that's
Thank
my
you.
2 cents.
Thank you. Thank you so much. And there's so much that we learn from you. Thank you. So, Jyotsna, should we,
Yes.
if there's no more questions, or no, I think we
And
can call
if
it
you have further questions down the line, you can always connect with us. You know where to find us on the AHP group. Yeah. Okay.
Thank you for joining, everyone. It's been such a pleasure. Go ahead, Jyotsna.
Thank you, everyone. And for those who have registered for the next workshop on April 29th, I'm sure you have already started with your activities there. So we look forward to hosting you for that particular workshop. And for our next HP dialogue, keep watching this space. We'll announce it. And we also have a course coming up. It's the Interprofessional Education course, which is an AHP KLE Higher Academy collaboration course. Is going to be starting from May 15th. The details of which are going to be shared with the HP members very soon. Those who are interested, please register for the course as well. Okay. Thank you so much and have a
Thank
great
you.
week.